Hi friends, good evening. I'm Dr. Ashutosh Gupta and I'm a consultant in fetal medicine. So today we are going to talk about very interesting case. Okay. So as we know that the congenital heart disease or congenital cardiac defects are one of the commonest fetal malformations to the tune of 0.7 to 0.8%, right? So can we imagine a situation in which we are having a DADC twin? So DADC meaning thereby that it is a genetically different and it is a fraternal twin. So genes are different, and both the babies could have a same spectrum of congenital cardiac malformations. Okay, so today we are going to talk about a case at a DADC twin that we identified as something around 13 weeks. Okay, so they are genetically different, and one of the babies is having a tetralogy of Falley, meaning thereby a TOF, which is a conotruncal malformations, which can happen, and the second baby is having a DORV, which is called as a double upright right ventricle. So, how on earth is it possible that probably is it my bad luck, even bad, that both the babies would land up some congenital malformation, and then probably we are landing up with some difficulty or the other, because then what we are dealing up with at the moment is a cyanotic heart disease. So a TOF or a DORV is the part of the one spectrum, which is a 22q microdeletion, and both of them are a cyanotic heart disease, meaning thereby that there could be some issues immediately after the baby is born, and depending upon the severity, we can have some cyanosis to the baby, and definitely the baby would need surgery after the baby is born, right? But the question is not this, but the question is this: how do you explain? So it is a pertinent question that how do you explain, meaning thereby that both the DADC twins is landing up with either with the TOF or with the DORV. So this is what we are going to learn in this video. Okay. So this is a 13-week scan, DADC twin. We are identifying the first baby. We identify subaortic VSD. The left ventricle is slightly dilated globular. Right heart is very small hypoplastic. Subaortic VSD, a large vessel arising from the so this is a aortic override, large dilated trunk, and then the pulmonary trunk is small hypoplastic. So a TOF. Second, this is a second T2. We identified subaortic VSD, and then we identified that both the great vessels are rising from the right ventricle and hypoplastic left heart. So heart left heart could not be visualized properly, and these are two vessels arising directly from the RV. So this is a double outright right ventricle, right? And so meaning thereby that both these things are conotruncal malformations, could be a part of 22q microdeletion, and they could be the part of the one continuum itself. Now how do you explain is this, that 90% they could be de novo, but 10% they could be inherited. Now mother could be a carrier. Now why did the mother is not manifesting? So this could be variable expression, incomplete penetrance, right? So, and there could be some genetic modifiers happening, and in a real world example we have identified that the mother is a carrier. So the plausible reason of identifying that why my both the babies a DADC twin, they are landing up with a conotruncal malformation. One is a TOF and second is a DORV. And the situation is this: in 22q microdeletions, 90% they are de novo. 10% they could be inherited. Inherited meaning that the father and mother could be carrier. But what we've identified is this, that the mother could be a carrier for this 22q microdeletion. Right, so we do have had examples in the past in which we've identified that the mother could be a non-manifesting. This could be an incomplete penetrance. She could be a mild speech delay. She could have a mild sort of an heart disease. She could be mild. She can have a mild scoliosis. Eventually, we identify that this is called as a variable expression. So, meaning thereby that out of the 7 to 8 sort of in clinical symptoms or a phenotype of a 22q microdeletion, she is manifesting only one or two, which is also mild and subtle, which are being missed, and therefore she never knew that she is a carrier for 22q microdeletion, and therefore the maternal diagnosis is being made through the fetus. So what we've identified is the ascertainment, maternal ascertainment is being done through the fetus. Since we identified that both the babies is having conotruncal malformation, the very strong suspicion of a 22q, they're a part of the continuum. So meaning thereby that instead of doing the CVS and then looking around for the baby, it is better that probably we did the test to the mother and the father. So mother first and the father second. So we did the CMA to the mother, and then we identified that she is carrying a 22q microdeletion. And so meaning thereby that she in being a carrier for this 22q, she is not manifesting. So this can happen with an autosomal dominant conditions. So we can have a variable expression, we can have an incomplete penetrance. She might not be manifesting all of the symptoms, but then she really passes on that genetic mutation to both the fetuses, and therefore the fetuses are severely affected. Okay, so this is a very good learning that the ascertainment or the mother could be a carrier for the genetic mutations, and therefore she is not manifesting that such, and therefore and passing on the genetic mutation to both the fetuses. Right, thank you very much for your patient listening.